Hello, good evening, everyone. I'm Dr. Jay Sardara, a senior consultant neurosurgeon at the Fortis Hospital, Mumbai. I welcome you all in our NSSA webinar series, and this is the sixth webinar, and we are going to discuss the very interesting webinar. This is very important because today we also have a special webinar. We have a collaboration with the British Association of the Spine Surgeons, and we are welcoming to all them. So today we have decided to discuss on the very common issue that is osteoporotic spine. And I'm sure that day-to-day basis, all the clinician we are dealing with that with a lot of enigma in the osteoporotic spine fracture management, which is still in the debate and the literature, like how to do the medical management. If there is acute back pain, will you go for the conservative or directly go for the vertebral augmentation technique? What are the surgical strategies? What are the vertebral augmentation method options, the novel medicines methods? And finally, how to prevent the post-operative failure of, surgically treated osteoporotic spine fractures. Very common surgical nuances need to understand by all the, spine surgeons all over the world. And we are very lucky and we are very glad to have all the known and renowned national and international spine faculty with us. We welcome you all and we start. I welcome with our chairperson. First of all, I would like to welcome Dr. Ramani sir. He is a living legend spine surgeon and he is a founder and the NSSA societies. I welcome Dr. Manas Panigrahi sir. He is a head of department at King's Hospital, Hyderabad, and he's a current NSSA president and NSI president. I welcome sir. Welcome Dr. Varnan Velo. He's a head of department in the Department of Neurosurgery, JJ Hospital, Mumbai. He's a past president of the NSSA. I also welcome to clear all the enigma. We have fantastic speaker lines, which is national and internationally acclaimed faculties. Dr. Shweta Budial is a DM endocrinologist. I welcome you. The Fortis Hospital, Mumbai. Dr. Si-Hun Kim from the Seoul Ancient Hospital, Seoul, Korea. Welcome, sir. And he's a very renowned international faculty. He has done a tremendous research on the clinical as well as research aspect on the osteoporosis. And we are very glad to have you, sir. Welcome. I would like to welcome Dr. Aprajay Golas. He is a consultant neurosurgeon from the Lancashire Teaching Hospital, UK. And he's a current president of the British Association of the Spine Surgeon. And we're glad to have you, sir. Dr. Harshad Dapke is a spine surgeon and renowned and known for the vertebral augmentation method. Will give you all the insight over the vertebral augmentation method, the decision making in the surgery. He's working in the Salisbury Hospital, UK. Welcome, sir. Dr. JKBC Parthiban, sir, senior consultant neurosurgeon, the KMCH Coimbatore, is a chief editor in the Journal of Spine Surgery. Very welcome. With no introduction. I welcome Dr. Apurva Prasad. He's a young, dynamic, and talented neurosurgeon. He will moderate this session. So, Dr. Apurva, now on you. You can start things.
Thank you very much, Dr. Jayesh. Just 2 points. First is I request all the speakers to kindly follow the time so that everyone gets an equal opportunity to speak and we have enough time for the discussion at the end. And all the discussion talks will be started with by the chairpersons at the end of all the lectures, which will be followed by a case-based panel discussion. We have 3 good cases for discussion. And without further delay, I request Dr. Panigrahi to please start the session and invite the speakers. Thank you. Dr. Manas?
Yeah, can you hear me? Yeah, good
Yes, sir.
evening. Good evening. I'd like to thank the British Society for participating with NSSA in this webinar, and I hope we'll have multiple webinars in future. I'd like to invite President Professor of Korean Society, Dr. Kim, to be in the program here, and we have Dr. Sweta, endocrinologist. Miss, she'll start with a topic which many of us need to know and learn because we do not routinely, it's not taught in our residency. Something which is not taught in residency, we don't practice in a routine thing. So I assume that in future, medical management of osteoporosis is given as much importance as only surgical management. Well, most of the time we only think of putting screws, putting cement, putting rods, but do not think of how to manage medically. I don't want to waste time because we have very limited time for each speaker, and I will request Dr. Sweta to give a lecture on osteoporosis medical knowledge.
Am I audible, sir?
Yes, yes.
Yeah. Good evening, everyone. At the outset, I would like to thank the organizers, Dr. Sardara and NSSA for the opportunity. So I'm going to talk about the overview and general preoperative assessment of the patients who present with osteoporotic vertebral fractures. So nowadays, we see that the prevalence of osteoporosis is increasing. And the reason for this is because the longevity of human beings has increased. Osteoporosis is the disease of aging skeleton. Like human beings are very peculiar species because of the fact that they outlive their reproductive lifespan. If we look at the peak bone mass accrual, it happens in the second decade of the life. During puberty, the bone mass increases under the influence of sex steroids. And somewhere in late 20s, early 30s, we all reach our peak bone mass. So our skeleton is the strongest at that point. And after the age of 40 or like 50, the bone mass starts declining more so in women because of the process of menopause and because of the lack of the sex steroids, decreasing level of estrogen, increasing level of FSH. This process also is seen in males, but little less pronounced. So that's why osteoporosis is more of a disease of postmenopausal women. And because now we live like beyond the age of 70s, 80s, the prevalence of osteoporosis and the osteoporotic fractures is increasing. So all over the world, the phenomena is seen, especially in India. What has been seen is prevalence is way more compared to developed countries. Like in this particular study from rural India, we see that prevalence of osteoporosis after the age of 70 is almost 50% compared to like the figures like 30% or 40% in other countries. And also osteoporosis sets in early in Indian women, probably because of poor nutrition, lack of vitamin D and calcium in our diet. So why we are worried about osteoporosis? Obviously, because it's associated with fragility fractures and increases the morbidity and mortality. Osteoporotic vertebral and non-vertebral fractures are associated with pain, disability, loss of independence, hospitalizations, future fractures, pressure ulcers. And osteoporotic fractures, it goes without saying that it is associated with economic cost to the family and also a burden on the healthcare infrastructure. So it, when we look at the osteoporotic vertebral fractures, it primarily increases the morbidity. But if I look at the hip fracture, a person who has osteoporosis at vertebral level is bound to have osteoporosis elsewhere. And as an endocrinologist, we are more worried about hip fracture because once a person has hip fracture, the risk of death in next 1 year is as high as 30%. The risk of death in next 8 years is 83%. So it's huge. So it's kind of a gateway to the heaven for a person who sustains osteoporotic hip fracture. And the risk of hospitalizations over next 8 years is more than 200% compared to general population. So osteoporotic hip fractures are associated with not only morbidity, but also with huge mortality. So it's important that the patients who are at risk are screened and detected even before they actually sustain fragility fractures. And we do have like well laid down guidelines as to whom should be screened. And how do we screen these patients for osteoporosis? The gold standard for screening and diagnosis of osteoporosis is dual energy X-ray absorptiometry or DEXA scan. And based on the DEXA scan basically measures bone mineral density. It's two-dimensional view of actually a three-dimensional structure. It does have many limitations, but at present, this is the best tool that we have. And we also have, like based on the T scores, the definitions of osteoporosis, someone whose T scores are below minus 2.5, either at vertebrae or the hip or the forearm are considered to have osteoporosis, whereas the T scores between -1 to -2.5 is considered to be in the range of osteopenia, and T score above -1 is considered as normal. For younger individuals, we use Z scores. If we look at Indian scenario, again, the DEXA machines are not widely available. So we have to kind of, especially in the tier 2 cities and rural area, may have to fall back on tools like FRAX, which is like fracture risk assessment score. And we do have India specific and other country specific FRAX tool where we can enter or populate this calculator with various demographic factors. And the factors which are enlisted here and which are taken into account while calculating the FRAX scores are precisely the risk factors for osteoporosis, like the body mass index. Individuals who are frail are more likely to have osteoporosis. Patients who have had previous fractures, the parental history of hip fractures, the current smokers or heavy drinkers, past history of glucocorticoids, patients with connective tissue diseases. All these are the patients who are at higher risk of osteoporosis. And if you come across a patient with vertebral fracture, which is sustained after a trivial trauma, this is what you have to inquire about. And we also have a tool called as vertebral fracture assessment tool, which is kind of a software embedded in the DEXA machine. It is kind of more refined X-ray of the LS spine. And based on the morphology of the vertebrae, we can actually classify the vertebral fractures into either wedge fractures or biconcave fractures or crush fractures. And the degree of fracture or the severity of the fracture can also be graded based on the decrease in the height of the vertebrae. And this is also one of the, I mean, because whenever a patient has multiple vertebral fractures, he's bound to lose his height. So historical loss of height of more than 2 to 3 inches, or on follow-up, you see that your patient is losing more than 2 inches of height. This is actually suggestive of presence of vertebral fractures, because many times vertebral fractures may be asymptomatic. The only complaint that the patient may have is some vague pains and aches, or the height loss that the patient may actually come across when you actively ask for the ask the patient. So what are the basic investigations that we should be doing whenever we come across a patient with fragility fractures anywhere in the body or vertebrae for that matter? There are certain basic tests that we are supposed to be doing irrespective of the age and the gender. And these are the hemogram, renal profile, calcium, phosphorus, alkaline phosphatase, vitamin D levels, albumin, and thyroid function as well. But if you think of secondary osteoporosis, it is not very uncommon. Secondary osteoporosis may be seen in at least 30% of the women who have osteoporosis and as many as 50% of the men who have osteoporosis. So it's not a trivial number to ignore. So if you think of secondary osteoporosis, you must do certain other tests as well. And when do you suspect secondary osteoporosis? When you come across osteoporosis or osteoporotic fractures in younger women, premenopausal women, all men, because osteoporosis is primarily a disease of postmenopausal women. So if you have osteoporosis in men, patients who are not responding to usual osteoporosis treatment, those who have severe osteoporosis, history of drugs like anti-epileptics, glucocorticoids, which are supposed to be risk factors, patients with untreated long-standing hyperthyroidism, hypogonadism, connective tissue diseases, and there is like an endless list of chronic medical conditions, which are all risk factors for secondary osteoporosis. Because it's very important to identify these patients, because these patients will require slightly different treatment approach. Until and unless you address the secondary or the underlying pathophysiological process, the osteoporotic medicines are not going to give you desired results. So in these patients where you suspect secondary osteoporosis, you would require certain other sets of investigations like urine calcium creatinine ratio, venous blood gas, or testosterone or FSH/LH prolactin in women when you suspect hypogonadism, workup for celiac disease, workup for multiple myeloma, workup for Cushing's disease, etc. And these, I mean, the test that you're going to order will depend on the clinical profile of the patients, the history and the physical examination and your clinical acumen. So secondary osteoporosis, I mean, osteomalacia is one factor which may closely mimic osteoporosis. But it's very important to segregate between the two. The two entities may just appear same on the DEXA scan. Both will have low bone densities, low T scores on the DEXA, but it's important that we segregate the two because the treatment is very different. Like there are patients with tumor-induced osteomalacia or primary hyperparathyroidism, parathyroid adenomas, or patients with celiac disease or drug-induced renal tubular acidosis or renal tubular dysfunction who may present with fragility factors, but in reality, they have osteomalacia. So, and these patients can actually be identified by just doing calcium phosphorus alkaline phosphatase in all the patients. And if any one of these is abnormal, it is very less likely that this patient has osteoporosis, and it's probably some other disorder related to calcium phosphorus or vitamin D metabolism.
Dr.
And
Shweta, kindly conclude.
yes, I think I've completed we already have a dedicated talk on treatment of osteoporosis. I think I can conclude here. Thank you.
Thank you, Dr. Sweta. We'll have the discussions in the last or?
In the last.
Yeah.
At the end. Yeah.
Very well. Thank you.
So, Dr. Sweta, you have to stay back till the end of the sessions for any questions. I request the next talk is by Professor Kim, and he from South Korea, and he'll be speaking on medical management of osteoporosis.
Okay. Second. Can you see my slide?
Yes.
Okay. Hi, good evening, ladies and gentlemen. I'm Dr. Kim from Korea. This is a great pleasure, and thank you very much for invitation to the NSSA webinar. So my talk this evening will be the medical treatment for the osteoporotic spine fractures. Okay. So actually the keywords and contents of my talk will be these 5. Bed rest, medications, bracing, rehabilitation, and finally the medical chemotherapy for osteoporosis. The osteoporosis is well known, most common metabolic bone disorder. And as the previous doctor also mentioned, there are a lot of the consequences from asymptomatic to very painful fragility fracture. And sometimes spinal stenosis and cauda equina syndrome rarely. And it is known as the silent disease without warning signs, or some doctors say a quiet thief, because usually osteoporosis is diagnosed at the time of the fracture without the previous warning signs. So in the osteoporosis, immediate surgical concerns and medical evaluation and the optimal treatment for the osteoporosis is important. Again, 1996, WHO defined the osteoporosis. Most of us know the T-score of minus 2.5 and below are the osteoporosis, as you can see in this table. But we have to remember, in the younger patient, men younger than 50, and premenopausal women and children, the WHO criteria of T-score cannot be used. For those patients, the International Society for Clinical Densitometry recommended use of Z-score. Z-score minus 2.0 or less are defined as the below the expected range for aging. So, and for these patients, they need to be searched for the secondary cause of osteoporosis. This is very interesting paper published by Turkish group. In the population over 50 years, 1/3 of women and 1/5 of the men will experience the osteoporotic fragility fracture in their lifetime. So it is very important to prevent osteoporosis. The next speaker will talk about the vertebroplasty and kyphoplasty very well. In the many literatures, the vertebroplasty and kyphoplasty gives very excellent, effective outcomes in the osteoporotic spine fractures. But look at this paper published in NEJM in 2009. This is a randomized trial of the vertebroplasty. They concluded the improvement in the pain and the related disability was similar in the vertebroplasty group versus conservative treatment group. What about this paper published in 2016? They emphasized the importance of multidisciplinary conservative treatment for the osteoporotic spine fracture patients, and this should be primary treatment. This, excuse me. So, in this paper published in 2017 regarding the non-surgical management in the osteoporotic vertebral compression fracture, they concluded, unfortunately, the current understanding is inconclusive for the optimal non-surgical management of the osteoporotic vertebral compression fracture. A couple of years ago, Korean group published a paper regarding the management of osteoporotic vertebral fractures. They mentioned if majority of the patients healed without a surgery, 15 to the 1/3 of patients finally need surgery. So customized surgical techniques are important, and currently no standard management is well known for the osteoporotic vertebral fractures. We can find many the algorithm for the osteoporotic spine fractures like this. They emphasized also in the osteoporotic spine fractures, pain management, rehabilitation, and fall prevention program are important. What are the principles of medical treatment? The first will be pain relief. Second, rehabilitation through the physical therapy and improvement of the quality of life and so on. And finally, assessing the risks and benefits. This algorithm is published by me and by Professor Ramani a couple of years ago as the WFN Spine Committee recommendations. We also emphasized as the non-operative treatment, chemotherapy, rehabilitation, strength, exercise, and balancing are important. So, again, regarding the non-surgical management, the first important thing is bed rest. And this is the published paper by Korean group. They compared the duration of absolute bed rest 1 week versus 2 weeks. Their conclusion was there was no difference in outcome, but complications like urination difficulty, constipation, indigestions are pretty much higher in the longer the bed rest groups. In this paper, they reported the importance of initial hospitalization and the rigorous bed rest. What are the medications for pain relief? Most of the doctors are using the analgesics such as acetaminophen, NSAIDs, opioids sometimes, and muscle relaxants. The muscle relaxant has many side effects such as drowsiness, dizziness. So the muscle relaxants are required for short term. What about the bisphosphonate teriparatide? They are well-known anti-osteoporotic agent having the pain relief effect. So by using the bisphosphonate and PTH will improve the pain in the osteoporotic compression fracture patients. The next is bracing. The usefulness of brace is pain relief, early mobilization, and preventing back fatigue. So the ideal brace should be lightweight, is to wear, and custom made. So these are some examples of braces using worldwide. Halo brace, Jade hyperextension brace, and so on. TLSO, personally, I like the TLSO with the shoulder rest, as you can see here. And some doctors are using ultrasound therapy. Even in Korea, many doctors are using acupuncture, TENS, heating, or ice application. But this treatment has no the evidence-based proof yet. The next will be rehabilitation. many the attempts to decrease kyphotic deformity are improving the paraspinal muscle strength, relax paraspinal muscles, and prevent falls in the future. So fall prevention is very important because this is the main cause of osteoporotic fracture. So for the older and frail patients, several interventions to reduce the risk of falling are important. And weight-bearing exercise, back strengthening, and balance training are also very important. There are some risk factors of the fall in the elderly patients. Environmental risk factors are lack of assistive devices, obstacles in the environment, loose throw rocks, and so on. What about the medical risk factors? This will be the arrhythmia, depression, orthostatic hypertension, dehydration, and so on. There are multifactorial interventions to prevent the falls in the elderly patients, such as the withdrawal of the psychoactive medications, such as sedative, anxiolytics, an appropriate exercise program, and partial hypertension treatment, and so on. This
Dr. Lim,
paper
kindly conclude, sir.
this paper emphasized the role of exercises. We can find many the articles regarding the rehabilitation and exercise importance. So long-term regular exercise program designed to improve postural stability, mobility, mechanical efficiencies, and the supplementary vitamin D and dietary calcium intake are very effective in preventing osteoporosis and falls. Lastly, chemotherapy. As the neurosurgeon, we need to prescribe the anti-osteoporotic the regimens to the patients, and the vertebral fractures are kind of indications for pharmacologic treatment to start in the osteoporotic patients. This table shows the category of the anti-osteoporotic agent. First is anti-resorptive agents such as bisphosphonate and SERMs and the denosumab and so on. And second is anabolic agents such as PTH and the abaloperitide and so on. And the basic fundamental supplement is calcium and active vitamin D in any cases. This is the algorithm for the drug treatment in osteoporosis. They mentioned the denosumab and bisphosphonate as the first line treatment. If this first line fails, raloxifene, teriparatide, strontium can be used. So regarding the bisphosphonate, this is one of the most widely used drug in worldwide.
Dr. Lim?
But we have to remember, in the oral bisphosphonate, it can induce the upper GI ulcer and disease. And what about the intravenous bisphosphonate? This can induce the acute phase reactions such as fever, muscle aches in the patient. I was so much honored and to express the gratitude to Dr. Zileli and my friend Pratibhan. We were able to publish the orthopedic spine fractures, WFN spine committee recommendations at the Journal of Neurosurgical Sciences in Italy a couple of years ago. It is 6 papers, and at this webinar, the last speaker, Dr. Pratibhan, will summarize the papers. These are the front page of the 6 papers we published. So this is my conclusion. Osteoporosis, this is quiet thief or silent disease without the warning signs. Again, in the population over 50 years, 1/3 of women, 1/5 of men will experience the osteoporosis-related fracture in their remaining lifetime. So multidisciplinary approach as the conservative treatment is important. And even though the current literature still supports medical treatment, endocrinologic management, and rehabilitation braces, they have not that much strong evidence currently. Thank you very much for listening.
Thank you, Professor Kim. for giving an overview of the medical management of osteoporotic spine fracture. We'll go on. I'll request Dr. Varnan to invite the next speaker. Dr. Varnan.
Yeah, good evening. I'd like to invite Dr.
Evening, sir.
Apurajay Gulash to give his talk, please.
Hello, everyone. Thank you for inviting me to give this talk. And I know your main emphasis was on solving the dilemma, what to do. So let me see if the slide moves on. Yeah. So I'm sure my audience is quite familiar with what a vertebroplasty is and what a kyphoplasty is. And just in summary, it is a percutaneous procedure, both of them, and they just under the X-ray, through the pedicle or outside the pedicle, getting in, putting in some cement, or trying to do a kyphoplasty when you're trying to jack it up, and then inject some cement in there. So that's effectively what these procedures are. The talk could be on this, like learning objectives, what these are, indication, and so on and so forth. But I noted that what you want from me is how we resolve the dilemma. And that's where I'll focus my talk. When I see this patient, I just share what dilemma I have and what I have developed over the last 30 years of this practice. So you always think about whether you intervene or don't intervene. And before that, my dilemmas here are, but does it work? Would it work in my patient? Am I going to do a kyphoplasty or a vertebroplasty? What I'm going to tell my patient to expect, how I'm going to do it, and all these type of things. And especially if it didn't work in the last patient, am I going to do one again in the similar one, the next one? Or why did it fail? As you heard from the previous talk, there is a conflicting literature. So how do I believe to what I read? And only way to read is when you experience and you see a good literature. But there is some agreement now that there is helpful in the acute setting. And these are a few papers that have been mentioned before. I think you need to be familiar with the NEJM paper and a vapor trial. These are important ones, and there are a few overview which has come out recently, which tell exactly what I mentioned to you just before. So if I am looking into it, I need to see, right, okay, what is the, when I'm assessing this patient, what's my dilemma? Is it going to work in this patient? Has this patient got a recent fracture? And I can assess this by the history or looking at the radiology image, if needed, with an MRI. And the most important, it is a dynamic, is there a mobility there? Like, is the pain worse when sitting? Because those are the people, when they're loading themselves, will have more pain. And I'll show you in a couple of more slides what we mean. And if there are multiple ones, which one is painful? So this I borrowed from this journal, and you can see it's done on the same day, same time. One is standing, and one is supine with the bolster behind, so like hyperextending. And this you can see just by positioning and expanding, and that can explain to you, right, okay, if you do something here, it's likely to work. Same way here, if you look at this fracture, just by simple positioning, you can see. During the procedure, we try to obtain it by making the patient lordose so that we can do, but in supine, you have to put something in the back. And if you see a cleft, which is indicating that there is a mobility there, and if it is correlating with the clinical history, which is the most important bit, then these things can work. So this is how you would perhaps think about, okay, something is going to work, so I'm going to do it. Next question then is, okay, what I'm going to do? I'm going to do a vertebroplasty, or am I going to do a kyphoplasty? So what's the comparison between? Well, obviously one is quicker, is less expensive, which is important to remember in today's economics, even in UK situation. And second, you have got the kyphoplasty, which is a better height restoration, but only I think in acute, because my experience with these, they don't look like you see in the cartoon that's jacking up. I never get as jacking up, and I feel it's an expensive vertebroplasty many times. So you have to be assessing that quite nicely. And maybe the dynamic X-ray is one indication to tell you whether it will work or not. And they say it's lesser risk of leak, but again, if you're careful, you can have the similar results with vertebroplasty as well. So how you're going to manage the patient expectation, what you're going to tell them. And that's the next thing. Am I going to tell them you'll be much better? Don't worry, you have this. Or am I going to tell them that, listen, it's going to improve a little bit, because your pain management has not worked in last few days or last few weeks. But remember, it may not work and there could be some complication now or in future. So this is also by the element to say, right, do I subject this patient to these things? Are they understanding what they're letting themselves in and what it's all about? So these are the sort of practical things that you will need to think about. And then you need to think, okay, you have decided going to do it. Patient is saying, yes, please do. How we are going to do it? Are you going to do a unipedicular approach? Are you going to do a bipedicular approach? Because it's important. If you're doing unipedicular, you may want to get needle beveled medially right to the middle so it can fill nicely both sides. Or you say, right, I go extrapedicular, whichever way. Am I using 1 C-arm or 2 C-arms? We use 2 C-arms because it makes it so much quicker. AP lateral, I don't need to make around, just very quick. I wait sometimes to do it in the evening when X-ray machines are free in the hospital, so I can get two together. Or borrow the suite in the radiology to see whether you can biplanar. So biplanar makes life much easier. How much cement to use? I'm just going to do 3 ml till I go till it leaks. What's the volume? And there is some interesting literature say that if you've done the good filling, this is showing as a biplanar, but if you've done a good filling, it gives a better result. So the endpoints could be when you're reaching to the posterior marginal vertebral body, you've got disc up to bottom and side to side, or the earliest hint that you've seen a leak coming in. So say, for example, as you see here, if you stop at what is B point here, you may feel it's enough, but it may not be because they've only given about 3 cc here. And this is our 7 cc. So you need to be thinking about what you're trying to achieve, especially if you feel the pain comes from the end plate going in or sucking in down there to the cleft. You want to fill it in nicely to give it the support that you want to give. Is another example here. You can see this patient actually has progressed very rapidly into this, and then filling in there. And when you're trying to do it, this is not the best needle placement. Don't accept the suboptimal. You're trying to start here. No, you start at around 2 o'clock position, 10 or 2 o'clock position, something like this, trying to get medially. But if you get like this, okay, you can accept, but then be mindful. Spot the leak earlier. Don't let it leak that much. So these are the things you need to be careful about. And this is the patient, same patient, was presented 2 years later with another fracture on the top. But this time, within 48 hours, pain is getting better. So we don't treat because last time we treated was very well. Doesn't mean you have to treat this one. It stayed stable for 4 years. So not every fracture, even same patient, needs the same treatment. This is a doctor actually who came in with a lot of thoracic pain. We were just seeing little abnormality and we we're not sure what to do with this. And about 18 months we carried on. Stir always positive. Finally, we got a SPECT scan, slight enhancement. She got enough, Isabel, do something. Osteoporosis was identified and then we filled up. She was so much happier. So even subtle signs, something like this can give you good results. This is the secondary we talked about before in endocrinology. Patient came with back pain. Within 3 months, he came like this. You would not believe, just back pain and 3 months you're seeing like this, which would ring an alarm bell. Investigation showed Cushing's. Very bad Cushing's just came out. Actually, I ended up doing his pituitary first before I did his back surgery. And then he came, which one to fill? So the SPECT helps you. So when there is a dilemma as to where to go, the SPECT helps you. And this patient then finally, poor chap, really had the problem. So I hope with that, I managed to clear at least some of your dilemmas as to when to do, how to do, when to stop, when not even to do. But I think some dilemmas still there and you learn from your experience. Thank you.
Thank you, Dr. Golash, for that wonderful presentation. I think Professor Amani is here. Professor Amani, sir, can you introduce the next speaker? Good evening to you. Unmute yourself. Unmute yourself, sir. You're
Ramani sir,
muted.
Ramani sir,
You're
please.
muted. You're muted. Sir, you're muted.
Right.
Okay.
Yeah. We can
Okay.
hear you, sir.
I got it. Thank you. Uh, I think I was already introduced by Seun Kim, during his paper. When I was the chairman of the WFN Span committee, we did some work on this and it was published into the journal. And he mentioned it here just now. So everybody probably, except probably Aparaj Gulash, I don't know whether he knows me or not. Everybody here, Indian, they know me well. Apurva, who is the next speaker?
The next speaker is Dr. Harshad Dapke. He's from the UK, and his talk is on surgical management, techniques, and nuances.
Yeah, please. Dr. Harshad Dapke, please.
Thank you. I'll just share my presentation. Just give me 1 second. Thank you for the opportunity to present this talk on surgical management of osteoporotic fractures. I work in a small hospital in Salisbury, in the south of the UK. Over the next 10 minutes, I will hope to cover when should we operate in this group of patients, what are our goals, what are our challenges, run through some tips and techniques, and if time permits, I'll show you some cases that we have done. So when should we operate? Well, it would be nice to keep the indications very simple. They are similar to the indications in the non-osteoporotic spine. So structural instability causing severe pain and deformity, particularly sagittal imbalance. These patients often get kyphosis with or without neurological instability. What are we trying to achieve? Well, we want to get rid of pain. We want to protect neurology. We want to restore sagittal balance. And this point is really very important because it does influence the complications that you sometimes get from this. And overall, we want to improve the patient's function. That's the ultimate aim. So we aim to do this by minimizing load bearing at individual fixation points and by maximizing the fixation strength in the anchor points. However, the osteoporotic spine presents numerous challenges. The first challenge is the patient. And as we all know, these are often elderly patients with several comorbidities. And like many surgeons, I too have been focused on the X-ray or the scan. So what I call surgical glaucoma. We get a tunnel vision. We just look at the fracture that is there on the image. But it's important to think laterally and think about the patient. We all know that the osteoporotic bone is soft. The screw doesn't get a good purchase, so screw loosening is common. Construct failure is the result of that, which leads to pseudoarthrosis. That is quite commonly seen in this group of patients, and that ultimately leads to sagittal imbalance. The metalwork can cut through. You get proximal or distal junctional kyphosis. And ultimately, in that situation, you have to consider revision. So if one is considering this type of surgery, you need to be prepared to do revision surgery. And if time allows, I'll show you one case where we have to do that. So by and large, in this group of patients, short segment fixations are pretty much not to be considered, perhaps. It all boils down to planning. And I will leave you with this very important dictum from Professor Bob Salter, who's famous for the Salter-Harris classification of epiphyseal injuries. He also described the Salter osteotomy for dysplastic hips. So we are, as surgeons, consider surgery to be very important, and indeed it is. But the decision whether to operate or not is crucial. And in order for us to help make that decision, it's often good to go through an MDT process. Certainly in my hospital, we have a weekly MDT. If the decision is made to operate, then we will do an anesthetic assessment, consent the patient appropriately. If you anticipate that there is going to be a complex surgical procedure, then do consider doing it on a dual surgeon list. So two consultants operating on each side, that often helps. And in my experience, it is certainly good for your own coronaries. If you can't do that for whatever reason and you're doing a solo surgeon list, which we mostly do, then make sure you can phone somebody for advice. Planning the procedure, decide what levels you need to do, decompress, what levels to fix. As I said earlier, we would consider longer constructs. Decide on the type of fixation that you would use, and we'll talk a little bit more about that in the next few slides. If the screws become loose or you don't get a good purchase, you need to think about fallback options or any adjunct fixation like hooks, wires. The other problem in severe deformity is that we cannot use instrumentation to correct the deformity, which is what we would do normally in other situations, and even in scoliosis, where you would use the metalwork to mold the spine to the shape that you want. You can't do that in osteoporosis. So you have to consider some bony procedures if the deformity is that bad. Again, that brings a different element of complexity to the whole situation. We all know what a pedicle screw is. I'm, as an orthopedic surgeon, tempted to look at biomechanics, but I won't bore you with that. Suffice to say that the pull-out strength of a pedicle screw is directly proportional to the volume of bone within the thread and the area of contact between the screw and the bone. So these two factors are certainly within our control as surgeons. Bone density isn't. When we are planning procedures, some surgeons advocate doing anterior procedure first, particularly if it's a stiff deformity or a severe deformity, mainly to mobilize the anterior column. And if you're doing that, you need good end plate preparation and avoid gouging the bony end plate, which can lead to graft subsidence. Also think about bone graft and BMP or a few other options. By far, the crunch surgery is posterior construct. Nowadays, we can manage with posterior alone surgery. And again, as I said before, consider long segment fixations. Avoid stopping at the junctional level or at the apex of the kyphosis. You may consider doing prophylactic vertebroplasty above and below the fusion levels. Why? Because it allows a gradual change of the Young's modulus. So when you put screws in a vertebral body, that segment becomes quite stiff. And the vertebra adjacent to it, which is not instrumental, is relatively soft and can fracture shortly after surgery. If you wish, you can use transverse rod-to-rod connectors. So there are these several options available for surgeons. Also think about bone graft. Autograft generally in this age group is limited. So you have to rely on allograft or even BMP. Let's go on to pedicle screws, which is our workhorse for posterior surgery. And as we say in the UK, in the osteoporotic spine, you often get only one chance, what we call one bite of the cherry. This is a very English phrase. But because you get only one chance, it is often better to do it right the first time. So if you have imaging, navigation, or robotic available in the hospital, by all means use it. One trick I've learned from my teachers is that with the osteoporotic spine, start with a small pilot hole. Don't use the standard pedicle finder, which is about 4.5 millimeters wide. Go for a 2.81. So you create a small pilot hole and then put a bigger screw in, which gives a better purchase. Depending on the level at which you're operating, you opt for a larger diameter screw, but make sure that you don't fracture the pedicle in the process. Longer screws have been shown to have better pull-out strength, but again, especially in the thoracic spine, be aware of the structures around the spine. Convergent screws give better pull-out strength than straight screws. Cortical bone trajectory, this is not in osteoporotic spine, but this has been described in literature. I just wanted to put it out there. The same applies to double screw technique. This has also been mentioned in some papers, and personally, I have no experience of this. I don't know if other panelists have used double screws. The other couple of points worth mentioning is that avoid hubbing of the pedicle screw. So when we put the screw and bring it straight down onto the spine, often the flute or the screw is touching the bone. So avoid that. Leave a little bit of a play between the tulip and the bone. And also avoid backing out of the screw. It has been shown that if you back out the screw even by one or two threads, you weaken the pull-out strength. These are the screw options that we have at our disposal, apart from the standard ones. Conical screws have been shown to have slightly better pull-out strength and lower insertional torque. I like hydroxyapatite screws, which we can order in our hospital. These give a good fit to start with, and eventually the hydroxyapatite bonds to the bone. Expandable screws are obviously have very good pull-out strength, but these are difficult to revise. Fenestrated screws, we'll talk about that in the next slide. So these screws are where you are cannulated screws through which you can inject bone cement. And some companies also have fenestrated dual pitch screws. So you've got a different pitch in the pedicle and different pitch of screw in the vertebral body, which is supposed to improve the pull-out strength. The only word of caution with these screws is that make sure the cement holes, which are these holes, are within the vertebral body. I have seen sometimes when a short screw is inserted, the hole, if it is here, the cement will leak into the canal and cause problems. But revision of these screws is difficult. If the screw becomes loose, often because of infection, then you got a loose screw with a blob of cement stuck like a lollipop at the end of it. So when you go to revise it, the screw may come out, but not the cement. Laminar hooks is an adjunct fixation. Angle laminar hooks can also be used. You can use a hook construct. Pedicle hooks, those of us who have done scoliosis will be familiar with this. It's an old style USS Type 2 kit where you can put this screw into the hook into underneath the pedicle and use a 3.2 screw to fix it. It gives a slightly better purchase than a sublaminar hook. One of the things that we keep available in our hospital is sublaminar wires, and these wires work like tapes. These are muslin tapes which you can put under the lamina, and it's often often a good bailout option because the lamina is made up of cortical bone, which is less affected in osteoporosis. And once you put this in, you can attach it to the clamp, which fixes onto any size rod, and you can tension this. So it gives a nice grip. What to do if the pedicle screw is loose? Well, check the trajectory and change carefully if required. Consider using large screws or fenestrated screws with cement. But one word of caution is that if you've already made one or two false passes into the vertebral body, you have made a big hole and the risk of cement leakage is quite high. Consider all the adjunct options. In the worst case scenario, if the pedicle is really empty, so the screw doesn't get any purchase, just abandon the pedicle and go to another level. I have met one or two surgeons who use allografts. So they use fibular allograft, which they cut into matchstick size pieces, which they put into the pedicle hole and then put a screw through that. I mean, I haven't personally had any experience with that technique. What is likely to come in the market? Well, we are going to have screws coated with bioactive implants. Vertebral stents are on the market. So that is often a good way to restore anterior column. We will get biodegradable cements or cements which have bone morphogenetic protein or endothelial growth factor, platelet-rich plasma, these sort of things. Just wanted to add medical option. Teriparatide has been described to improve the pull-out strength. And this paper by Autori described the use of teriparatide in the post-op period, which led to improved fusion rates in osteoporotic spine. Whereas the second paper that I referenced, they used teriparatide 1 month before surgery, and they found that they had better screw purchase. This denosumab has been approved by FDA, but I am not aware of any studies about that. So just running through one or two cases, this is a 68-year-old male.
Dr. Das, kindly conclude, please.
Okay.
Yes, sir, kindly conclude.
That's fine. I'll leave you with this last slide. This is Stonehenge from close to where I live. Thank you.
Thank you, sir. No, Dr. Vernon.
Yeah, thank you, Dr. Harshad, for that wonderful talk. And now I'd like to invite none other than Dr. Parthiban, who's going to summarize the whole management of osteoporosis and also highlight on the WFNS recommendations. I think we should all know that he has done a lot of work with Dr. Kim and Dr. Mahmood Zileli on this topic, and we are eager to learn from what the inferences they have drawn. Over to you, Dr. Parthiban. Are you there?
I'm here.
Dr.
Is my able to see my screen? Or
Yeah. Go into
you see my screen?
Sir, full screen.
Go into slide mode. Yeah.
I don't know how to make it
Sir,
slide.
that play would be, I think, good enough.
Go on to play. Play. Go into slide.
Yeah, but it's not there. And
play in this.
Play. Press play and see. There is a play icon there.
Yeah, but I'm not able to.
Play icon.
I'm not able to because something is hiding. And can I go ahead with like this?
There is no play there. We can see the play.
Yeah.
See if you can go into the full screen. Yeah. Play on that. Yeah.
It's not happening.
So then the top note, the keynote line, there is another play option after view, and before window. After view. Yeah, play slideshow, topmost. Play. After view, there will be a play. First one.
Yeah, full screen.
There is a play slide.
I did that. It is a full screen.
It's already full screen.
Can I go ahead?
Play slideshow.
First one.
Play slideshow. Top one.
Yes.
Yeah.
Okay. Sorry, I think.
Yeah. Okay.
Is that okay? Because something is coming in between. I'm not able to close this. Anyway, sorry. I think I have something is coming in between this. I don't know how to take it off. Are you seeing this one?
Yes. Very.
1 second. I'm not able to. How to close this?
You can escape.
Just escape.
Same.
Okay. I'm sorry. See, before I go to this, these are the some of the articles we prepared from WFNS Spine Committee during the time of COVID period. It was a very tough time, and we had a tough time to prepare these articles, and we were very happy to publish to about 6 articles it was published in 2022. Basically, we have divided this into various aspects, but then we came to some conclusions like this. On this, you don't know how. I think we have passed, and you're able to see my slide.
Yes, very clearly.
Yeah. See here, there is the osteoporosis is more common in North America, and what it says is that any patient with osteoporosis or above 50 years likely to get worsen over a period of time down the line, and they get some kind of a fracture. 1/3 of the patients end up in fracture somehow. And some patients who are with basic treatments like conservative treatments, they like to get better off in about 6 months' time. This is the statement which we found it in the overall collective studying the articles which we went through that. So finally, what it says is that these patients are likely to worsen, and we have to do something on this. The preventive treatment is like active lifestyle, nutrition, good nutrition, physical therapies, and medication, as described earlier. The predictors of fracture risk fracs is very important in our studies here to decide on the treatment of osteoporosis. And dual energy X-ray absorptiometry alone and history alone need to be combined together to come to a conclusion to say whether this osteoporosis is really symptomatic and we need to give the treatment. The first line is being it's a calcium and vitamin D, the first line being. So that is the first line as far as the world says totally. The second line comes the biphosphonate in positive risk patients. And or there is a previous fracture which is associated, as one of our speakers showed, Ajay was showing that one kind of a case with the previous fracture. The third line is coming as the denosumab and the parathermon, that is the teriparatites. So these are the reason ones at right now. We say, so the grade one, that is the first line, the second line, the third line, and all medications should be continued for 5 years. These are the statements which we came in conclusion after our thorough study. After 5 years, there should be a pause, and you observe the patient. And if there is going to be again symptomatic in conservative line, then we have to go in for another course of treatment, or we have to think about augmentation procedure. Now, when augmentation procedure were described, this classification this is from the German classification, DGOU. So this classification makes very simple. Like here you can see type 1 and type 2 OF, that is the osteoporotic fracture type 1 and type 2, you can treat conservatively. But all other things from type 3, you can see the worsening of the burst fractures. That is, the end plate comes down, the both end plates comes down. In all these things, we need an augmentation or instrumentation. Whatever I am saying are all the statements finalized at the end of our analysis by the WFS Spine Committee. The literature, as usual, was very conflicting, having conflicting studies. Hence, we've decided that none of the literature study can be taken into account. So we need a better quality and better design studies further in future for the world. There are meta-analyses which are inconclusive of the effectiveness of the vertebral augmentation. Hence, patients need to be counseled very well about the effectiveness of vertebral augmentation, but at the same time with giving the benefits of the conservative treatment and the complications of the vertebral augmentation procedures. That is a very important thing. This is an important statement which we were able to conclude. There is no correct evidence for timing. We concluded less than 6 weeks on the onset of severe pain is the best time for vertebral augmentation. There is less than 6 weeks of pain onset. There is no statistical difference between the unilateral or bilateral approach or the amount of cement is being used. And there is no statistical difference between different vertebral augmentation technique like kyphoplasty or vertebroplasty. It is still into doubt that we are not able to come to any conclusion. It is left to the surgeon's experience and his way of selection and his expertise in that particular procedure. As far as the open surgery is concerned, the indication is only very clearly the open surgery for is one is a painful kyphosis and if there is a neurological deficit. And if you don't have these two things, then you can just do a percutaneous vertebral augmentation procedure. Here, as I said, this German classification here, type 4 and type 5, are considered as unstable. However, we still do not have a definite statement to call which OVF is considered as unstable, because there are many patients who live without any symptom but have a very, very bad vertebral collapse. That is the beauty of this disease. So the type of surgery is also individualized, like our last speaker was talking about it. It is, it depends on whether anterior or posterior, it is individualized. And if there is a rigid kyphosis, then you need to go for anterior and then put the posterior long rod fixation. For surgical correction of kyphosis, multiple techniques need to be adapted, not a single technique. So one has to improve it. You have to add on a kyphoplasty or a vertebroplasty along with that. There are some techniques to improve strengthening of the screws, as Harshad was talking about it. We believe in bicortical purchase, longer, wider diameter screws, cement augmentation. And the best one is to avoid overcorrections. Segment augmentation increases pull-out strength, but there is no amount of cement. How much amount of cement still is not being standardized. Augmented screws are better than non-augmented screws. What about the implant failure? Implant failure is very common in the open surgery. It is not uncommon. The other complications are pseudoarthrosis, screw loosening, and proximal and distal junctional kyphosis. The techniques to prevent the failure or to achieve the sagittal balance by either you do a good interbody fusion or an osteotomy as needed, decrease the load on the upper vertebra by using hooks and vertebroplasty, and decrease the instrument rigidity, as he said about a very nice, he showed a nice tape there, and with the hybrid systems. So these are the statements. Whatever I said now, these are the final statements which we drafted down by studying about 10 years articles which were published in the world literature. All the English literature, we went through the many English literature, and these are some of the statements we concluded. So to summarize, osteoporosis is the most common disorder and is most difficult disorder to treat as well. And it is not yet clearly said, except in few conditions where if you have a kyphosis and there is an increased pain, neurological deficit, you go in for an open surgery. And if it is not so, then you can choose any vertebral augmentation procedure as you wish. Another important point is about the medical management and also the investigations. The medical management, as far as the vitamin D and calcium, it is okay. Beyond that, biphosphonate, and if you want to teriparatide, it is always better to involve the endocrinologist to do the extensive assessment, and surgeons to stay as surgeons and give the endocrinologist to be part of the the whole treatment of osteoporosis. In any part, another important thing is that many times we like to conclude or stop the treatment within 2 years' time or 3 years' time, but then our study has suggested very, very clearly it should be for 5 years. For example, that we start for biphosphonate or teriparatide, it must go on for 5 years and reassess the patient. During this time, you can do the DEXA, you can do the other investigations, whatever investigation is possible to assess how much the patient improves. Thank you very much for your attention. Thank you.
Thank you, Dr. Parthiban, for that good elaboration and showing us all the indications and the preventive measures. So I like to thank all the speakers for staying in time. And over to Apurva.
So I would request the chairpersons and the panelists to kindly start the discussion. And after that, we will take the case-based panel discussion.
So
if there are any questions for the speakers, we'll take them now.
Thank you, all the speakers. Very, very nice discussion and presentation. It's really eye-opening. The question for Dr. Shweta. So all the speakers have at the end concluded that medical and perioperative management is also most important to prevent the failure what we are choosing, either conservative or surgery or vertebral augmentation. So in perioperative management, depend upon DEXA scan like -1, -2.5, or more than -2.5. How do you take a call that will you add zoledronic acid or bisphosphonate, or will you add denosumab, or you are okay with the Terifac for 1 month and after 3, 4, 5 months? How do you decide?
Right. So we already have very well laid down and evidence-based guidelines, and the choice of therapeutic agent will depend on the severity of osteoporosis. Somebody who has osteoporosis and already has fractures is considered to have severe osteoporosis. Similarly, patients who have T-scores below -3.5, who have had multiple fractures in the past, or who are having fractures or already who are on treatment and then they have subsequent fractures. These are all considered as high-risk individuals or patients in whom there are already osteoporotic fractures, and for some reason they have to be on medications which are further going to perpetuate osteoporosis, like patients who are on glucocorticoids because of their connective tissue diseases. So these are patients who are considered to be high risk. We generally choose injectable bisphosphonates like zoledronate or teriparatide. We don't have abaloparatide in India, or denosumab. So for patients with severe osteoporosis, they would require long-term treatment, and it's a good idea to start with anabolics first. Anabolics are the agents which increase bone formation. That's precisely PTH and PTH derivatives, the teriparatide. And once the patient has completed at least 2 years of teriparatide, then they should be put on anti-resorptives, which could be bisphosphonates or denosumab. If there are some contraindications for teriparatide, then you can think of directly anti-resorptives. There are some studies of combining both agents, but they have primarily looked at increase in the bone mineral density and not at the hard outcomes, like actually the number of fractures that the patients had subsequently. For patients who just have like mild osteoporosis, no osteoporotic fractures so far, you can give oral bisphosphonates or based. I mean, also have to the other factors that you have to take into consideration is what does your patient prefer. Like he's very averse to injection, then there's, even though teriparatide or the other anabolic agents are the most effective use, if the patient is not going to be compliant, the cost of the treatment, especially in our Indian setup where the resources are really a challenge. And all these factors do matter. I think it's the severity of the disease, the patient's affordability, as well as how willing he is to take a particular agent is all that matters. And especially for patients who have renal disease, those who already have, you know, uh, CKD and metabolic bone disease, then a lot will depend on their calcium profile, the bone turnover status at that point of time, etc.
And so you said that teriparatide is better than denosumab, and denosumab should be tried later, not before, right?
At spine, I would say that the bisphosphonates, denosumab, and teriparatide all would fare similar. But at the level of hip, the anti-resorptives are better than the anabolics.
Any other question, Apuru?
The sequence is important. Anabolics followed by anti-resorptives. If we do the reverse, the benefits are not going to be that great.
Right, right.
Can I discuss about this? Would like to discuss with the endocrinologist
Yes, sir.
about one particular thing, the pre-operative preparation of the patients, right? So this is what we are much interested to know about it, because many times when the patient comes to us with the indication for surgery, but by the time the patient is already has it's very painful. So we do not know. I'm talking about the surgeon. We see the patient when the patients are referred to us for surgical intervention. Now, by that time, we do not have much time to start the preoperative anabolics. But as Harshad also and Apajay also was talking about it, that the puller strength is increased if you use teriparatide about at least about 1 month or 2 months before that. Now in this scenario, how will you work up that if you are going to see the osteoporotic patient on the first line that we see? Will you use any classification of the fracture along with the symptoms to define which medicine you have to start?
Yes, as I mentioned earlier in the discussion, the type of agent will depend on the severity of osteoporosis. If the patient already has fractures, like either they are hip fractures or osteoporotic vertebral fractures, irrespective of the T scores on the DEXA, that would be considered as severe osteoporosis, and the choice of agents would be the injectables, either zoledronate or teriparatide or denosumab. And if the patient like has pain, as it has been shown earlier from our personal experience as well as the literature, actually the bisphosphonates and the teriparatide would help for the pain relief. When we start them on these agents, apart from the other measures that we implement for pain relief, these also help the patients to have better pain control. Whereas denosumab is known to aggravate the pain, musculoskeletal pains for a while, or even on long-term basis, the patients may keep on experiencing some muscular skeletal pains. So that's one advantage. And about increasing the speed of healing or the rapidity of fracture healing with teriparatide versus bisphosphonate, we don't have like a lot of evidence to really say that the teriparatide would increase the bone formation so rapidly as to it would promote the healing in short term. But it's personal experience of many orthopedic surgeons and spine surgeons that when they give teriparatide for a few months, they actually see the better healing. There are like a couple of studies with conflicting results, but because teriparatide promotes, it's not just anti-resorptive, it's not anti-resorptive, it actually promotes bone formation. I think it makes sense to give teriparatide. And these patients with severe osteoporosis, most of them are going to require sequential therapy. Just one agent is not going to be enough. So I think we should start with teriparatide and then transition them over to some anti-resorptive, either bisphosphonates or denosumab, because whatever benefit that they have gained with anabolic teriparatide, that has to be maintained. The bisphosphonates or the denosumab will actually increase the bone density further, not only at the level of the spine, but also at the hip where teriparatide is little weaker. And it will basically, whatever benefit the teriparatide has brought about will be maintained and the further bone mass increase will be seen. So sequential therapy is what is more beneficial in patients with severe osteoporosis. And if we start them on denosumab, like if the patient is very averse to having daily injections, we can very well start them on denosumab because it's just once in 6 months injection. But we have to remember that it's going to be a long-term treatment. Like long-term is like really long-term for 10 years. And if the patient stops the treatment prematurely, they can actually experience rebound vertebral fractures. The patient shouldn't stop denosumab prematurely and shouldn't miss the doses or shouldn't delay. If for some reason they are not able to take the injection in that particular month, it is better to prepone the injection rather than postponing. And if for some reason they have to stop denosumab, it has to be followed by bisphosphonates to prevent rebound osteoporosis and bone fractures. So that is one thing that we have to remember. So just like few doses of denosumab or few months of teriparatide is not going to be of a help. The process of remodeling is very slow. So the treatment for osteoporosis is essentially long-term. Unfortunately, we have very few tools in our armamentarium. So we have to choose very carefully and appropriate duration of treatment. That's, I think, of paramount importance.
Very nice.
Can I ask some? Okay. Can I ask a question to Dr. Aprajay? Now you said you give 1 month of treatment and then go for surgery to increase the pillar strength. Is it your observation or it is a literature-based study?
I think this was the statement from Harshad. So I will invite him to make a comment.
Okay.
Can I just interject? In the study that I referenced in my talk, they looked at two groups of patients. It's a small study, about 16 patients in each group. One of the groups had teriparatide, and they had they measured the insertional torque of the screw and the pull-out strength as well on table. And there was a significant clinical and statistical difference between the two groups. So it's a short study. I don't know how much we should read into that, but it's from 2014, and I haven't seen anything else, any big study in literature about teriparatide preoperatively.
Um, uh, I have another question, Dr. Aprej, that how do you decide about the site of pain when you have multiple fractures? You told about clinical, but is there any role of doing a bone scan to decide the site of pain, or only clinical is the best way?
Manas, I don't think clinical is as accurate because we used to feel right, okay, we'll go and palpate the spinous process and see, yeah, this is standard. But that actually, in my experience, not as specific because people sometimes have pain differently. So the two things that we use is A, the stir sequence on the MR, and secondly, the CT SPECT scan. And if there's a correlation, good correlation between the CT SPECT and the MRI scan on the stir, that's the ideal. Sometimes there's a disparity. The stir is positive and CT SPECT not showing much, or vice versa. Then how do you go about this? Then sometimes you take the clinical situation perspective to see what was the previous radiograph, which has progressed, which is most likelihood, and put a little bit to the palpation and things like this. But it's a combination of everything together. But in terms of investigation, we very much rely on CT SPECT, which is very helpful for us if that is the dilemma.
Before we move ahead, Apurva, so we have 2 or 3 very, very interesting case. So it also involve all the question, and during the discussion, it is clear out all the dilemmas also. Apurva, can we go ahead for cases?
Sure, I'll just start my sharing 1 second.
So
So we have 3 cases today for discussion. We'll be starting with the second case because it's a relatively easier and a straightforward case. So this is a 40-year-old female. She's obese without any comorbidities. History of trivial trauma 1 week ago. She had presented 2 months before. Then she had a trivial trauma again, and now she has come with severe back pain. So she has 2 MRIs. These are the images which we have. This is the first one. I'm sorry. This is the first one, which she has a D12 compression fracture. We can see the evolution here of the fracture. This is a collapsed segment on the right side. This is the X-ray, which we have. So I would request the chairpersons and the speakers to kindly comment on the management for this case. Dr. Manas, I think you can start the discussion, sir.
Yeah, no, this is a young female, no, 40 years.
40-year-old, yes, sir, obese.
With so much of osteoporosis and severe trauma. So, first I think the investigate for the cause of osteoporosis in this young female to like exclude myeloma or exclude any hyperparathyroidism, find out the cause for osteoporosis, and then plan the treatment. Any other investigations are done for this patient?
No, sir. This is the data which I have for this case. So I don't have the workup for her, but these are what is available.
So I think I have seen this patient, and probably DEXA scan suggested of severe osteoporosis, -3 or something.
Okay, T-score, yeah.
Yeah, I mean, what I mean is at 40 years, you do not find osteoporosis so early. So I first think that it's a pathological fracture rather than an osteoporotic fracture. So,
okay, sir.
Yeah.
So if it is considered as a suppose osteoporotic fracture, the same scan, so how will you go ahead, sir? Which will you directly go for conservative or augmentation or fixation?
No, if this patient has means this is an unstable one, and the patient has severe pain, like I'll go for the posterior cortex is intact. We first go for augmentation, augmented pedicle screw fixation. But with osteoporosis, my experience has been very bad of implant failure, even if I have used the augmented screw. So earlier I was using that, but nowadays I am very conservative in the osteoporotic spine. I first treat the disease, give them bed rest, treat the osteoporosis for 3 months, and then go for, if the pain still persists, go for fixation.
Okay. Dr.
So
Aparajay,
this is a junctional lesion at D12 vertebra. Would that
Yes.
be taken into account when you are managing the treatment? We can see a compression behind on the dural sac. So would you be worried for this patient, provided that this is at the conus and the patient may dare into a bowel bladder incontinence? Would that be
I
an
Yeah, I when I was like you, I was very aggressive in fixing, but now I am very conservative. I ask for complete bed rest, treat osteoporosis first, and then if pain persists, go for a fixation. The only thing is because the junctional level, I'll go 2 level above and below. I'll like others comment also. This is what I follow now.
Dr. Aparajay, you raised the hand.
Yes, I did. Means obviously, I won't consider this patient as obese because looking at the fat on the MR on that area doesn't look that bad. But nonetheless, I don't know the time difference between the two scans, but she's developing a bit of kyphosis. Ideal time to capture her, in fact, could have been the time of the first scan if she didn't had pain relief within 2-3 days. She was bedbound. At that stage, at the scan 1 stage, I would have just done a vertebroplasty if she was in too much pain. But if she has come back after the second scan due to some reason and pain is still very severe, really very severe pain, we would, because now it has consolidated and I think sometimes it's like Leaning Tower of Pisa. It just goes up to some degree and doesn't go anymore. When the upper and bottom contacts come together, it's not going to do this. So we nowadays, unless we get it in the right place, I don't think it's very unstable now. We would still think about seeing whether it's a dynamicity, like whether it opens up in posture by doing a supine X-ray, putting a blob in the back to see if it opens, in which case just a vertebroplasty may be enough. Or young patient maybe think kyphoplasty. We won't rush into fixing it at all. And we are not worried about the conus here at all.
Despite that, your anterior thecal sac is little bit compressing, still you go for this kyphoplasty?
Yeah. Absolutely. Means we do it in MSCC most of the time because now our practice is using these more in MSCC than anything else. And there was this concept of, okay, if there's a posterior cortex is breached, there is a problem. And in MSCC, there was a concept that, okay, you may push the tumor out. With many of these, you have to be careful. You have to be just interior. I had none of them causing any cord compression. Only time it causes problem is somebody is not cautious and just keeps on pushing and get the cement in the canal. Those are the only complication I've seen. But otherwise, just doing a limited 2 ml, 3 ml, not a problem.
Right. I think Dr. Harshad has raised the hand.
Yes, thank you. This is an interesting case. And what we would do in my hospital is we would get a standing X-ray of this patient. As Aprajay said, we would see the difference between the sagittal alignment in the supine and standing position. Generally, if the local kyphosis is 15-20 degrees or so and is maintained in the standing X-ray, so it doesn't collapse any further, then we would do cement augmentation alone. If the kyphosis then increases substantially, then we would think about instrumentation. Again, as I said in my talk, 2 or 3 levels above or below. With regards to cement augmentation, in this case, I can see a cleft in the vertebral body. So the superior end plate will be quite thin. And if this opens out, then I would consider doing a kyphoplasty or a vertebral stent. One little technical thing that I have done at times is that when you're using 2 balloons, as Aparajay said very rightly, that when you take the balloons out, the whole end plates collapse again. So you don't get a height restoration. In order to get around that, I have filled 1 balloon with radio-opaque dye and the second one with saline. So I put the radio-opaque dye balloon in first, inflate the end plates, restore as much height as I can, check how much dye I have put in, how many cc's of dye. Then I go in on the other side, inflate the saline balloon with the same amount of saline. So if you have, say, 3 cc's of dye in, I would put 3 cc's of saline in. Hopefully, the saline balloon will hold the end plates apart when you remove the other balloon. Do you see what I'm saying? So when you're injecting cement, on the opposite side, the saline balloon is still inflated. So the end plates are still apart. And that sometimes works. With regards to posterior vertebral, where the fracture goes into the posterior vertebral body, one other technique, which is kind of wrist technique I have learned, is that I inject a little bit of cement, 1 to 2 cc, before the balloon goes in. So you inject the cement in, take the cement cannula out, immediately put the balloon in. And while the cement is still soft, you inflate the balloon. The idea being that the cement, the cement sort of wraps around the balloon, creating a neocortex. So when you take the balloon out, you got that neocortex protecting the rest of your cement from extravasation. So hopefully you won't get as much leak as you would have had otherwise. Because in this case, I think leak is quite likely.
Right, right. But one thing is very, in flexion and extension, you said, what you see means, do you think so that at D12 level, this you said that if kyphos, that segment is open in the local kyphosis, how did you decide the instability in flexion and extension? Means
No, I believe that question is for me, is it?
yes, yes.
I didn't say flexion extension, it's just a standing lateral X-ray.
Standing lateral X-ray, what did you see? Is it because this
You want to see the local kyphosis?
So you want a weight-bearing X-ray versus a non-weight-bearing X-ray?
Sorry, I didn't hear that. Come back again.
Is that a weight-bearing X-ray while standing versus a non-weight-bearing supine X-ray? Do you want to compare the dynamics in that?
Correct. Supine versus standing. Correct.
Okay, so you meant to say if there is an increase in the collapse, the height of the vertebral body is reduced in the standing X-ray, then you suggest it is unstable, right? Is it so?
Correct.
Okay.
So with
I just mentioned what we follow in our center.
So can we move to the second case, Dr. Jayesh?
Yes, sir.
Before you go, just ask one question.
Yes, sir.
When do you think kyphoplasty will not work? Is there any duration from the time of fracture till after how many months you should not do kyphoplasty, or it is possible all the time?
I'll share my experience, and I can let Harshad say. In my experience, anything which has become more than 3 to 4 weeks old, it hardly really opens up properly, unless there is a cleft in MR, and unless by doing this supine X-ray with the bolsters behind, you have been able to show that it is opening up. You need to train your radiographer how to do these X-rays. They must hyperextend the spine to really show it that is changing. So if it is, then yes, but anything old X-ray, in my experience, they never really open up in kyphoplasty as much as you would like.
Now, looking at this X-ray, what is given, do you feel that kyphoplasty can be done in this?
Kyphoplasty is better determined not on the X-ray, but on the MRI scan, if I could. So if I go back to the MR, there appear to be a cleft. And, but having said that, I'm not seeing the fluid in the cleft. It seems more black, whereas it's getting sclerosed perhaps a little bit. So it's not the high intensity signal in the cleft that you see which opens up. I suspect this will not open up.
So if you say if there is a fluid, it high chance to open.
Yes, if there's a fluid, very high chance to open. Yes.
Okay. Absolutely. If you see the X-ray also, it's like sclerosed, and which is again in MRI also it looks similar. I'm sure this is more than 3-4 months old. The second.
Yes, this was saying that the boat is missed. When patient came in was ideal because there was no kyphosis, there was good position. If you fill it at that point, you're done. But it's a catch-22. At that time, do you think, well, can I avoid it? Maybe in the next few weeks, pain will get better. And by next few weeks, pain doesn't get better. It get more collapse and make your life difficult.
So, Dr. Arshad, after suppose you have done kyphoplasty, will you continue this teriparatide for 3, 4, 6 months with the same patient?
Yes, we would continue treatment for that.
You also,
Yeah,
Dr.
and with regards to this case, I would also add one more thing that if we were to do cement augmentation at this level, T12, I would generally consider doing a unipedicular fill in T11 and L1. So I would might do right on one at one level and left on the other, just to inject maybe 1 or 2 cc of cement. As I said in my talk, to harmonize the Young's modulus. You don't want the spine to go from a very stiff level to soft level. So to reduce the risk of adjacent segment fractures.
May I be a bit controversial, Harshad, on that? Means I think
I
I
know.
have to take it. Yes, I have to accept it as a expert's choice, perhaps, rather than anything else, because you're not augmenting here anything. I can see where you're coming from, but on these scans, there is no real evidence so far that they are losing anything there. So yes, yes, and no. I want the audience to at least take that. No, this is not only thing to do. You can do it, but yeah, it is just our opinion. It is not much
Indeed.
evidence on it.
Apurva, we can
Indeed,
go.
couldn't agree more.
Very
Okay,
nice.
we'll go to the next case. So this is a 71-year-old hypertensive hypothyroid female, low back pain since many years, more than the last 2 months. The pain score according to her is 7 out of 10. She has some stomach fullness. She walked with a stooping gait. She's already using a LS belt. She has cramps. She's walking without support. She is stooping but walking without support. She has an urge incontinence. She has constipation. Clinically, the right lower limb is weaker than the left. All the reflexes are absent. There's no spasticity. The plantars are flexor. She has had multiple falls in the past. She's lost count of it. And she presents to the OPD with this picture. So I'll just zoom in on the X-ray first. This is the X-ray, wherein we can see vertebral collapse at 2 levels here. Going radiologically, this would be L2 and L1. We also see one anterior and superior end plate concavity in the lower level. When we come to the MRI, interestingly, she has a D9 collapse as well, along with the L1 and L2, and the L3 body is concave here. So, and if we go to the transverse section, these are the corresponding levels at D12, L1 radiologically. These were at the level below. The dorsal screening completely has not been done. We don't have the transverse section at D9, but these are the two vertebral bodies which are collapsed. I would request Dr. Vernon to please start the discussion for this patient.
Yeah, basically you will have to do the same thing because mostly this is an osteoporotic spine. And
Yes, sir.
only thing is there are multiple levels. So the best thing would be a kyphoplasty in this patient. Okay. Now, given the number of vertebral bodies which are involved, okay. So I don't think it'll be one symptom in this patient. It won't be only
Yes, sir.
pain.
So she has pain while walking. She has lower limb weakness. She has urge incontinence. She has constipation.
Yeah.
Obviously, she has some paresthesias as well. I've seen this patient in the outpatient department.
Yeah, because
And she was using someone had given her lumbar belt, not using the Taylor's brace or anything.
because
And so,
given
if you
that
advise for a kyphoplasty, would it be at all the 3 levels?
the ones with the anterior collapse and this one, can you see the D8? Is that D7 or D8?
That's D9, sir. That's D9.
D9.
The upper one. This is D9. 10,
Yeah,
11,
so that
12, L1 and
definitely
2.
requires, and then the first one below the skip. Now the L1 is not that bad. The
Yes,
posterior.
I'll just go to the X-ray as well. Yeah.
Yeah. So two levels would be ideal, and then you wait and watch and give her medical therapy if she's osteoporotic. If she was younger, I would have probably gone for a long segment fixation.
Stabilization. Okay, sir.
Because she's got hyperlordosis also down.
Yes, sir.
So,
Okay, thank you, sir.
I think Ramani sir have any comment? Ramani sir is there. Oh, Ramani sir is there.
He is not in the chair. He is not in the chair.
Okay.
Parthiban sir, like
Yeah, Dr. Parthiban.
any change in the plan?
Uh, no, means that if I now Dr. Apreja, like means you see hyperintensity only in two bodies, so only you will go for kyphoplasty vertebrate or only those two or the others.
Dr.
Uh,
Apreja?
it's a tricky one. It will be good to see the stir as well as they are just all plain T2s,
Yeah.
but certainly those two are showing the cleft, and I suspect those two are the main source. This is not a good surgical candidate. So also all the other symptoms are not just coming from vertebral collapse like the incontinence or there's not enough canal compromise to have neurological symptoms from that. I think they are all related to other things. Here mainly is the pain that's coming from these fractures, and on that basis, if I get chance, I will get the stir. I'll treat medically, and at least we go with those two to start with. Maybe a CT spec would be useful in a scenario like this, but those are very clear. Those two with the cleft seems to be the one to go for to start with, and then you see how you get along. It may not be just in one session. You do something, wait and see what happens, and then take it up further. But I would rush for any surgery except for those two levels.
So you
I
mean
think most important, Apurva, in this case is you have to counsel this patient properly. The important
sir.
thing is counseling because you can't expect miracles in them. And the patient
Yes, sir.
should not go with the impression that it's going to be miracle surgery. So it's very important
Absolutely, yeah.
to counsel these patients. Yeah.
So, Vanessa, would you consider a brace for this patient either before or after the procedure? A tailor brace?
Brace would be a must in this patient. Now, only worry is the hypolordosis down. If you see,
Yes, sir.
you've got a hypolordosis down. So sometimes once you do this, they might come back with pain down. Okay, so it would be a custom-made designed brace for her. It can't be the normal brace which you give. So that
Yes, sir.
that is very important. That's it.
Now, Dr. Kim, how he would like to,
Kim?
what medical management you want to prefer for this, in addition to the brace and kyphoplasty?
Yeah, this patient has severe back pain plus the radicular pain. Can I take a look the symptoms, the upper slide?
Yeah, they're on
Can
the
I
screen,
see?
sir.
Yeah. So I mean, she has the cramps in the legs and the right lower leg, the weakness. So, besides the kyphoplasty, I like to do some decompression surgery. So we can do the endoscopy, the heart issue, unilateral biportal endoscopy at the L5S1. And the upper levels, I think they have the stenosis. So we need to relieve the radicular the symptoms in this patient. What do you think? The decompression surgeries, the audience?
You would not like to fix it because we can see there is a
No fixation, just decompression. Using some MIS techniques, endoscopic techniques.
Okay.
So a kyphoplasty with a decompression, a minimally invasive technique.
Yeah. Yes, that's it.
In the
Dr.
history,
Parthiban?
the radicular pain was in which distribution? The clinically.
So she just has a lower limb weakness. There is no radicular pain, but definitely she has, cramps in both the legs.
Yeah, I mean,
But clinically, she had a right-sided weakness.
Yes. Leg cramps.
Yes.
And walking the gait difficulty.
Yes.
Right?
So it is a gross instability, I guess. Because there's a gross dorsal kyphosis and lumbar hyperlordosis.
Yeah.
So,
can I make a comment?
Yes, Parthiban sir.
Yes, Dr. Parthiban, go ahead.
Yeah, this discussion is very good, and actually, Dr. Kim has gone to focus at the lower level for the symptoms of the lower limbs. Probably, I think that's the reason he was recommending for the endoscopic discectomy, endoscopic decompression. But then, when you come to the this D12 and L1, it's not looking good. Absolutely not looking good, and these kind of patients may tend to progress further. So I personally will feel that we have to address this. Doing just vertebral augmentation and wait and watch, I'm not very sure how far this patient is going to be absolutely on the walk for the next few years. So I would prefer to do a long segment fixation. Though Aprajay was telling that this patient is not a good candidate for fixation, but I personally feel, but the amount of kyphosis here is not looking very satisfactory. And also, if you go to the X-ray, can you go to the X-ray, please? Yeah,
Yeah,
here,
yeah,
here.
yes.
Yeah, if you look at this D12L1, this is a very, very unstable. It looks pretty unstable. So
Mm-hmm.
I think we may have to address that. And that is not going to be addressed without a stabilization and or an interbody fusion. Because I personally feel that maybe we have this dilemma of where the pain come from. But then if you have a dynamic views, probably we know what exactly happening at D12 and L1. As I said, that if we do an hyperextension and then you do an X-ray and you find it is reducing, even then, I personally feel that these patients may go further bad in due course of time. So in that view, if you ask me, I would prefer to do a posterior fixation in a long posterior fixation. But at the same time, I will also try to address the vertebral collapses with vertebral augmentation and maybe it's a pretty big surgery. But then that's the way this may have to be thought about.
So I guess
But
you
then for a
start.
71-year-old female with severe osteoporosis, would a long segment fixation hold, and how
See,
sure are?
I think, yeah, I'll come to that. See, this 71 years, yes, this age is definitely considered, but we do not know exactly. See, we are just discussing only on the paper, but we do not know how the patient really looks like. Like some patients are even at 70, 71, they are much stronger. But then I'm not very sure about this patient, how the build, how the physique. I'm not able to. But then the quality of life is very important. And if you look at the quality of life and the ages he has uh, further down the line for living, I think we have to give some quality of life.
Yeah.
Okay, noted. Oh, so we move on to the last case.
Sorry,
This is
Apurva, can I just
yes, sir,
ask?
please, Dr. Abhijit. Yeah.
So, what risk would you quote this patient? Because in my experience, this type of patient will have around 30-40% morbidity risk, risk of wound breaking down, screw pulling out, wound failure, top level breaking off. So, if we are talking about a very high complexity, what risk would you quote this patient?
Yeah, agree with that. Yes, certainly this high risk surgery. That's what I said. This is a daunting. It's a high risk surgery, no doubt in that. But then a reasonably good fixation with a brace will give a better quality of life. Why I say this is because we see quite a bit of patients like this, but generally they don't agree for the long surgery. And for vertebral augmentation here, uh, I'm not very sure how far it is going to give a long-term result.
And would you then consider like not just stabilization? Would you like really do a?
You are mute, sir.
I'm on mute. I realize that. Uh, would you just put the stabilization, or would you really be going for a proper fusion, uh, putting bone between and trying to get it all
The,
stick
the
together?
yeah, I will say that you mix with the instrumentation with there is one place D12 and L1 where significantly you can see the uh, instability signs. Then we can do the interbody fusion at that level alone, and the other places you can do a cement augmentation, particularly the L1 and L2. Those are the areas.
Can I just make one point here before we proceed to the next case? That is, we would get a whole spine X-ray here because what is happening at one end of the spine may well be driving something at the other end. So we are focusing just on the thoracolumbar area. But if, especially if, as Dr. Pathiban said, and I would agree with you that in our hospital, if she is considered for decompression, we would do instrumented fixation here, going up to into the high thoracic spine. The big question is what is happening to the rest of the spine?
Yeah.
What is the sagittal balance looking like? Because in this case, looking at the fractured levels, I think getting Jamshidi needles into those vertebrae, they're almost tending to be vertebra plana. And I would find it difficult to position my needle securely, and the defect will be an uncontained defect. So the cement is likely to be go into an uncontained area. That would be my concern here.
So, Dr. Arshad, suppose you are taking this patient into T, and we can see there is a L1 who is completely collapsed. So, I guess you will fix from D10, 2 level above or 3 level above, and below up to L3 because that is the last normal vertebra. And you put a fenestrated screw, and per se, suppose you are putting a cement. And then what will be the strategy to correct the kyphosis? You just distract and osteotomy, or you would like to fix in situ?
In this case, we would stop the fixation maybe at L5, and we would span these segments and go higher up into the thoracic spine. We wouldn't stop there at, because you are going to get problems at this level here. Is it D9 you said? T9 level.
D9, yeah.
So you have to go up to maybe T4 there. So we are talking with, as some other panelists said, it is a big operation. And this is something that we would put through our MDT process. And if and only if it is through that mechanism, if all colleagues agree that this is what we should be doing, then we would counsel the patient very carefully. As Aprajay said, I think what we tell patients is the risk of minor and major complications is 100%, and the risk of revision surgery is 300%.
So it is
despite that, that may be a bit harsh, but it just puts them in the picture. And if they still feel that, okay, fine, the patient is fit and she's willing to consider surgery, then it has to be done in experienced hands. Somebody who does this on a regular basis. And certainly in the UK, we have centers who specialize in this type of surgery. So we'll refer the patient there.
But you will have to go to the sacrum also. You will have to take sacrum because of the hypolordosis. That's what. Going at L5
go down, even consider iliac screws. Yeah, I see your point.
So in that case, I think Dr. Panagri said that only 2 level kyphoplasty or vertebroplasty and just stabilization of that focal segment would be less morbid. Don't you think so? If you compare both the option, one is extensive large surgery and one focal segment vertebral augmentation.
Absolutely, that's certainly an option, and we would seriously consider that, bearing in mind that you may have to deal with a PJK or DJK whenever it happens, or if it happens.
We'll put it on the patient's choice at then, right? At then.
Indeed. Counseling is
question to Dr. Harshad. I have one question, Dr. Harshad. Do you have experience with the cortical bone trajectory screws?
Cortical bone trajectory screws, not in the osteoporotic spine. We have used them in degen spine, but not in these cases, no. In these cases, we generally tend to use either, as I said, conical screws or fenestrated screws. If we are not happy about fenestration, then we would go for HA coated.
Okay. But that is what is in osteoporotic region and degenerative osteoporosis, CBT screws also are equally good. That is what at least the literature says.
Yeah.
Oh, yes. Yeah. It has been well described. Yeah.
Yeah. In fact, this cortical bone. Hello.
Yeah. Yes.
In fact, this cortical bone trajectory is actually very interesting. Though they look very bad in the X-rays, they are more effective. Because the perfect screw placements are not going to hold because in osteoporosis the cortical bones are more stronger than the obviously. So I always prefer to put my screws a little bit angulated so that in the pedicle itself we touch two ends of the cortex inside. So if you see the Weinstein's old Weinstein's point, Weinstein's trajectory, and the new ones, that is from medial to lateral, I prefer them if I am not going for any cement augmentation, just for screw fixation. So I usually deliberately traject my screws in a different directions in osteoporotic fractures.
And can I just add
Thank
that
you.
looking at the axial MRI scan, I just thought her pedicles looked a little slender. So
Yep.
getting about 4.5, 5.5 screws will be difficult. It won't be easy in her case. So I would
Yeah.
consider those sublaminar bands.
Yeah, the pedicles are very small in the dorsal
Yeah.
aspect, pretty small.
So we'll just come to the next case now. This again has been given by Dr. Jayesh. This is a patient who has already been treated with vertebroplasty at one level and has presented to him with persistent pain. Now, these are the images which we have. So as we can see, L4 vertebroplasty has been done. And these are the obviously the post-operative images. We don't have the initial ones. But on the X-ray, we can very clearly see that the patient also has a collapse at this is L1, and these are dynamic scans which have been done. This is the AP view on the X-ray, and these are the MRI images which we have.
So patient present with many months after vertebroplasty and already treated for osteoporotic treatment with this dynamic instability, with severe back pain and radicular pain. And young patient.
Dr. Sehun Kim, if you can please start the discussion for this case.
Yes. How old is she? The patient again? How old is the patient?
Apuro,
Dr. Jayesh.
age is there? No, he approximately
No.
40, 50, sir. He was very middle age.
50s.
Not old.
Okay.
Young,
Where
well,
get
healthy.
the MRI? I think I like to emphasize the importance of enhanced MRI images.
Okay.
Sometimes we see the infected spondylitis in this case, such a cases. So to start optimal treatment, I think we need to take the MRI enhancement study and the lab as well to rule out the spondylitis because the patient has not only back pain, severe back pain, but also you mentioned the leg pain.
Yes, yes. But after a long time, sir, this patient came
Yeah,
after
so I like to
3 years, so
the
less chance of infection. Means
yeah, so I like to rule out infection.
So contrast enhanced MRI would be one investigation which
Yes,
you would do. And provided that
yes.
there is no infection in this case, because the patient has presented after quite some time after the first procedure, then what would be the plan of action, sir, for management of this patient?
Hmm. So you mean when the infection is ruled out,
Yes.
no infection
what do
is
I do?
Yes, sir.
Hmm.
So we do
Actually,
have
I cannot see
yes.
the axial images in this patient, but I think if
Can you show the eggshell cut, Sapurva? Because there appears to be canal stenosis there.
Yes, I know. I don't have those
We
cuts
have
with me
this only.
currently.
We have this only. Yes, there were grade 1 or grade 2 spondylolisthesis at L4 level. There were pseudodisc prolapse. There were canal stenosis also, but that is because of this listhesis also. So there were radicular pain because of this also. But the point is that L4 5 listhesis L4 are already vertebroplasty.
So if you see, there is a almost grade 2 recessive here at
Yes,
L4 and
and it is
L5,
2 year old. I guess 2 year old patient.
and it's a dynamic on the extension scan. The recessive is not so much. On the flexion, we see a good amount of recessive, almost made in grade 2.
So now if we are planning,
So this listhesis was not existing when vertebroplasty
Yes,
was
yes,
done.
of course. And at initial level, it was not there. It has been referred from somewhere else.
Uh-huh.
Now he presented with after 2 years with L4-5 instability in which L4 has already, vertebroplasty has been done. So now how we plan the correction of listhesis in this? This is
And so would we concentrate on this L1 vertebral collapse as well?
Not at
If
all.
this is a pain generator? No.
No, actually, I wanted to ask Dr. Golash the same question after his presentation. Is at L4, L5, do we only do vertebral augmentation? Because I have never done it till now. If we do augmentation, I do a good decompression and I also do a pedicle screw fixation, which is a complete procedure.
Okay.
So
at the lumbar level. I have never done just an augmentation and I will never do it. That's why.
At L4, L5 specifically.
What we say, Dr. Vanan, is we say never in medicine. So it all tailors to individual patient. If the patient is only come with back pain, has no stenosis, like the case I showed, there's no stenosis, there is no other problem, is only just that bone fracture, I will find very difficult to justify. Easy to do, it's not a problem, but I find difficult to justify to put that patient through something, thinking of what will happen in future, where at that point, patient only needs that augmentation. But here is a different scenario. And here, obviously, your patient just come in with progression of problem, a degenerative problem perhaps at this time, which is causing the slip. Obviously, we need to see what the facets are like and things. But it's not the biggest problem. Means you have solution. If you need to do decompression at this area, you can. Question here would be how you're going to stabilize this. Options would be you can go from 3 to 5. You can drill through that vertebroplasty and put the screw through that drill. It's entirely possible to do that as well. You can come lateral and do a lateral fixation. You can come anteriorly and do an early fixation. So there are various ways to deal with this problem, But just because this may happen, I would encourage you to try just lower lumbar augmentation only in patients with no stenosis, no leg pain, just the acute fracture that has come through. Uncommon to see because most come at thoracolumbar junction, I must admit. Or supportive fracture in lumbar spine are not so common. Many times we just find occult or collapse because of myeloma or because of malignancy, those type of problem. But that's a different problem. So I don't think because patient had the vertebroplasty before, it's very difficult to deal with. There are various ways to deal with this problem.
So you will put a screw in L4, and which kind of screw you will put?
Yes. So what you do is, I don't know what systems you have, but we do have drill. So you can have you put it with the MIS type drill. So you take the drill and you drill through, and it will create a trajectory, and it will take a screw.
So through in vertebroplasty vertebra means there is a cement.
Yeah. You can. It's a solid vertebra. It will take a screw, and the posterolateral fusion. But it's great too. It's getting just to get through. It's not the best for anterior only. Posterior strength would be better. So I will prepare that way. And if I fail to get there, I'll go from L3 to L5. I decompress that area and go L3 to L5.
You will not take S1?
No. There's no need here. I can't see any compression at S1.
Okay.
And so you will try for both the pedicles in L4 as anchor?
Both the pedicles, yes. Okay. I'll take both the pedicles.
I think Dr.
Say for example, I had a patient like this where, in fact, what Dr. Punj said is very right. Patient got infected in this area. It was a thoracic vertebroplasty, and patient came with a positive SPAC, and somehow it just got infected. So I had to convert it to a vertebrectomy. So you go in, you take out the vertebrae, then it's easy to do. The whole slab comes out. So you do a vertebrectomy, and then you just reconstruct the area with the cages and things. So if it turns out to be infection, it's bit of a problem because just I tried inpatient antibiotics for 2 months, 3 months. It was just not getting there. It was a wishful thinking, so I had to get rid of it, and then patient did very well. So if it's infected, then you may have to think about those.
So what is the normal duration in which patients present to you if there has been an infection post the procedure?
Our patient came a long time, like yours is doing. It was a delayed presentation. So maybe about 18 months or something like that. Must be heterogeneous sort of spread is not like happening because cement gets very hot and they're supposed to kill even the nerves. The one of the mechanism supposed to be is getting hot and so it should sterilize itself to some degree if it's getting to that hot. But must be a secondary infection during a later period.
So it is already 9. So just last quick answer I need from Dr. Harshad and Dr. Aprajay. One screw, if you are putting augmented screw with cement, or you are doing vertebroplasty, how much ml is safe and how much in your practice you are putting? If you are putting augmented screw, is it 1 ml, 2 ml, 3 ml? Vertebroplasty, 1 ml, 2 ml, 3 ml? At single level screw, single level vertebroplasty.
It really depends upon the thank you, Aprajay. It really depends upon the number of levels that you're putting the fenestrated screws in. Usually, if you use 1 pack of cement, you can get max about 4 screws. There is a little bit of wastage, but unless you got a very efficient scrub, those who can do 2 packs of cements at the same time, and you got another assistant who does it, it gets quite tricky because you're also looking for cement extravasation. So I would just do one at a time. I wouldn't do both together. And generally not, in my experience, not more than 1 to 2 cc per screw.
And for vertebroplasty?
That much actually is enough to give you that cement coverage around the screw thread to give you a better purchase. That's what you're aiming for. You're not aiming for a good big fill like as you want in a kypho or a vertebroplasty.
Why I ask this question, because many delegates are interested to know this particular point. So it is 2 cc approximately at 1 level for vertebroplasty, right?
So my experience is slightly different because what I tend to do is I try to make use of the collapsed spine as well. So there, what I tend to do is I just like do vertebroplasty. So you're putting about say 2-3 cc and put a screw immediately afterwards, so that I don't need a fenestrated screw. So I've taken but fill it with the cement and then put the screw immediately after there. So this screw is taking in, and that allows me to lessen the length of the construct that I may have to do. Otherwise, yes, it doesn't really matter for the cement. 1 cc per screw is enough because it is all about those little spikes that comes around this. Because you're trying on those, they are not the collapsed one. So 1 cc per screw is enough.
Okay.
I think one other important point to consider is which levels you're doing. So lumbar vertebrae, max they will take about 4 to 6 cc also if you go in the really low ones. But thoracics is difficult to get more than the 3 or 4 max. I wouldn't dare to put more than that.
Fine. So Apurva, can we stop the things?
Yeah. Definitely, sir.
Yes, quick last comment, sir.
Yes, sir. Please go ahead.
Apurva, it's not a comment, but I sincerely have to thank my friends Shehun, Aprajay, and Harshad for accepting our invitation from NSSA. It was very nice of them, and to say immediately yes. And it is not that easy. They have rescheduled their surgeries. In particularly, Harshad was planning to go for one. Aprajay was very busy yesterday, and my dear Shehun is still awake in Korea.
Yes.
And I talked to him 3 times to find out whether he will be okay for
Probably
this time.
1 a.m.
For him, it is very late. It must be early morning, I think. I'm very thankful. Apurva, please carry on.
Yeah.
Thank you so much, sir. Dr. Jayesh, if we can conclude this session.
So I absolutely, from the bottom of heart, I would like to thank all the chairpersons, Manas sir, Vanan sir, Ramani sir is also there. Thank you so much for your time. And this was a wonderful discussion we are held on. Because of time, I would not like to summarize, but I would put a summary and I would put it in the group. All the speakers and our Dr. Aprajay, Dr. Harsha, Dr. King, thank you so much for your time. Dr. Parthiban, thank you for your guidance to make this webinar very interesting and discussion. I would like to thank Apurva to do a fantastic discussion and moderation. At the end, my special thanks to the Osteopore company. They are our education partner. Mr. Vandan Patel is there. So Mr. Khoon Singh, the Director of Global Marketing of Osteopore, and Vandan Patel is the Director of Indian branch of Osteopore and Ulstro. And they are our education partner for this webinar. and we would like to thank them. Actually, who doesn't know about the osteoporosis is basically a bio-reabsorption implant, and that convert to natural bone in sometimes. And it's the first kind to be successfully developed and can be used for human surgery, including osteoporosis also. Very interesting. And thank you so much for their support. Thanks all the delegates to join this webinar. Almost more than 120 delegates were there and who enjoyed. Thank you so much and good evening.
Big congratulations to Jayesh and Apurva for doing a wonderful job. Okay.
Thank you so much, sir. If you are still in the operating room, we can see.
Yeah.
Yeah. Thank you, Dr. Joseph. Thank you.
Thank you.
Thank you, everyone. Thank you. Good night.
Thank you. Good night.
Bye-bye.
Thank you.
Good night. Thank you.